we will move on to Dr. Renz. This is, after all, a surgery symposium, so we have to talk a little bit about surgery. And I apologize to all of our friends from internal medicine that are here. It might be a little bit boring, but if there's one message to take home, it is that there is maybe not one procedure that fits all when it comes to chronic pancreatitis. Our next speaker is Dr. John Renz. Dr. Renz is professor of medicine, and he is the vice chair for program development here at Downstate. He was instrumental in building one of the most prestigious liver transplant programs in New York City at Columbia. He then became a chief of transplantation at the University of Arizona, and later was directing the liver transplant program at the University of Chicago. And now he has joined us just a few months ago, and he's going to talk about the standard surgical consideration as treatment of chronic pancreatitis. John?
Well, thank you so much. I'm so sorry. I won't want to steal Reiner's thunder, and he knows this far better than I do. But I will just talk about some of the basics of the standard surgical considerations in the treatment of chronic pancreatitis, and I have nothing to disclose. So, as we know, chronic pancreatitis is really a progressive inflammatory disease of the pancreas, and it's characterized by irreversible morphologic changes. Here we see a diseased pancreas. It's clearly fibrotic and scarred. And the accumulation of these morphologic changes results in chronic pain and ultimately impedes endocrine and exocrine function of the gland. The incidence is roughly 15 per 100,000 population, but as we know, that varies dramatically with geography and socioeconomics. So the etiology of pancreatitis is important, especially for the surgical management, because some of the operations lend themselves better to certain etiologies. And while we're all familiar with toxic and metabolic alcohol-related chronic pancreatitis, there's certainly idiopathic, a genetic predisposition to the disease, can be associated with autoimmune diseases, as well as anatomic abnormalities of the pancreas, like pancreativism. And it's really kind of with all inflammatory diseases, there's really a three-hit hypothesis, which begins with the sentinel acute event. There we go, okay. Which begins with the sentinel acute event or the sentinel acute pancreatitis event. This is usually triggered by some environmental stressor, but can certainly be genetic. And then, of course, there's an inappropriate upregulation of inflammation within the organ, and that leads to an overabundance of pancreatic injury and an altered immune response that continues this injury pattern, leading to chronic inflammation. And of course, chronic inflammation is associated with ischemia, glandular ischemia, whether it's the pancreas or the liver or any other, or it's all the same. This results in moving of collagen and fibrosis, ultimately leading to pain and then endocrine and exocrine loss function. But we're all kind of familiar at a kind of superficial level with the idea of chronic pancreatitis. But the pain is also associated with glandular dysfunction, so it's commonly associated with weight loss, malabsorption, fatigue, steatorrhea, and then ultimately with loss of endocrine function, diabetes. And these patients are developing pain in kind of a multi-centric modality. Not only do they have pain associated with hypertension within the gland, ductal hypertension, inflammation of the celiac trunk, but then all the physiologic impediment that comes with it kind of accelerates their plight. So you have GI dysmotility, poor malabsorption, fatigue, and all this turns into a kind of chronic pain syndrome that is multifactorial in origin. Radiologically, chronic pancreatitis looks like this. This CAT scan has all the classic features: ductal dilatation, calcification within the gland, and pancreatic tissue atrophy. Now, when you look at the inflammation, right, you have complete replacement of normal parenchyma with collagen and scar tissue, right? It begins with a neutrophil infiltration. This causes local ischemia and inflammation. The macrophages move in to kind of clean up the cell debris, and then the lymphocytes result in formation of chronic collagen as they recruit collagen to fill the areas of ischemia. When you look at established pancreatitis versus end stage, you certainly have fibrosis, exocrine and endocrine insufficiency, and there's a small incidence of duct-associated adenocarcinoma. The intrapancreatic complications, and looking at the complications is essential because it's going to help you decide what kind of operation may best suit your patient. And certainly the intrapancreatic complications include duct strictures and stones, which are common, pseudocyst, splenic vein thrombosis with associated portal hypertension, especially peripheral vein thrombosis, which can give kind of localized vascular hypertrophy, venous hypertension in the field of resection. There's gastric and duodenal outlet obstruction. Often there's an inflammatory mass in the head of the pancreas, which can be misdiagnosed for adenocarcinoma and requires very careful imaging and workup. Biliary obstruction from stenosis of the common bile duct, as well as portal vein thrombosis and pancreatic cancer. The extrapancreatic complications are also significant because the pseudocyst can extend into the retroperitoneum or the mediastinum. You can have a duct leak with ascites and fistula formation, metabolic disease, and of course all this predisposes to infection, SIRS, and multisystem organ failure. So when you look at the plight of the unfortunate individual who has chronic pancreatitis, it's not uncommon for them to have a persistent chronic history with a lot of narcotic use. They've often failed multiple different therapies by many different providers. And they've also had a lot of treatment options like endoscopy and plus minus even TPN. So you have a patient who really has difficulty both at the physiologic but also at the psychosocial level with respect to gainful employment, intrafamily relations. The entire thing is just a very unfortunate situation. Now, there are multiple studies that have conclusively shown that surgery is superior to chronic endoscopy, and perhaps the most famous was a New England Journal of Medicine article that really categorically looked in a prospective randomized trial versus chronic and ERCP therapy versus surgery, drainage procedures and surgery. And it showed a lowered pain threshold, approximately double that of endoscopy, with overall improved health on an SF-36 form. And there was no difference seen in hospitalization, complications, or pancreatic functions. So for at least the last 10 years, there's very solid data to show that surgery is superior to chronic endoscopy. I don't know what happened to the slides. Is there? There's some kind of, This is a Mac conversion error. Maybe I'll just see if I can. Now it won't do anything. Okay, that's okay. So ERCP is inferior to surgery. So let's talk about some of the most common surgical procedures. Now, one of the slides that is broken basically says that you can categorize the procedures into a drainage procedure, a resection procedure, or a drainage and resection procedure. So we'll go through each of the three categories. I'll give you kind of the historical update. A lot of this surgery hasn't changed for decades, and the results are pretty standardized, and they actually haven't changed much either in the last 20 years. Of course, we all know the Puestow procedure. Prior to Puestow, there had been a lot of work with sphincterotomies, limited resections of the tail of the pancreas, plus minus the spleen, and what were called retrograde drainage procedure. This is Puestow's original paper from 1956, and actually the operation from his paper is not what we historically think of as the Puestow. This is his drawing, and basically at the time there was a lot of work with distal pancreatectomies, including the spleen, plus some form of retrograde drainage procedure. And what Puestow did was not only took a smaller piece of the distal panc, but then he opened up the main duct and then kind of imbricated the intestine, a roux limb, over that. So this was Puestow's original description of his operation, and that's a pure drainage procedure. And that was modified into what we characteristically think of as the Puestow by Partington and Rochelle. And this was done in 1960. And instead of doing the distal pancreatectomy and the splenectomy, they preserved the spleen, filleted the main pancreatic duct, and then brought the roux limb up to be a side-to-side bowel to pancreas anastomosis, preserving the spleen. So they eliminated the splenectomy, they eliminated the distal pancreatectomy, and they greatly extended the opening of the major pancreatic duct. This is kind of how historically we view the Puestow. And interestingly, the first long-term results of the Puestow were actually reported by Irving Enquist and Duval. And Enquist was a faculty member, actually, at SUNY Downstate. So, coming across the literature, how could you not include talking a little bit about Downstate and its role in chronic pancreatitis? And this was published in 1961. So at the end, the upside of the Puestow is that it's a limited drainage procedure for principally major ductal disease and not head of the pancreas disease, which, as you know, is typically the site of most of the inflammation and pathology. So it's thought kind of that the head of the pancreas is the motor or the driver for pancreatic pain, and often the area of its principal inflammation. So if you have distal disease, isolated disease, certainly the Puestow has applicability. Another upside is it's rather easy to do. It's been done open, it's been done laparoscopic, it's been done robotically. There are multiple papers in each one of these modalities, all of which show similar results. But it has very limited efficacy, with better results actually achieved in children historically than in adults. Now, away from the kind of isolated drainage is the pure resection pancreatectomy, right? And here you can either have a distal pancreatectomy, which we see here, right? You can have a Whipple, right? Or you can have a total pancreatectomy. And the kind of the advantage of the Whipple is when you have a lot of extra pancreatic manifestations of the disease. So, for example, you may have persistent gastric outlet obstruction, you may have stenosis of the duodenum, you may have cholestasis secondary to a biliary stricture. So when you're having extra pancreatic manifestations, then certainly the Whipple is a useful tool for head of the pancreas disease, which includes an inflammatory mass in the head of the pancreas. The distal pancreatectomy has really limited applicability and has been kind of receding from the general surgeon's armamentarium for chronic pancreatitis. Of course, when you talk about the Puestow and you combine the drainage plus the resection, that gives you two very common procedures, one called the Berger and the other called the Frey, right? The Berger is typically favored by the Europeans, and the Frey has been typically favored by the North Americans. And basically, you see both of them here, but I'll go into detail much more in a moment. And basically, the Frey is technically much easier, right? What you do is you basically do a Puestow, and then you extend that incision to include the anterior component of the head of the pancreas, and then you use your roux limb to kind of drain the entire pancreas, including the head and the major duct. The Berger is a little bit different in that they actually resect the head of the pancreas and then use the same roux limb in a much more sophisticated reconstruction, which I'll show you in a moment. So starting with the easy, the Frey procedure was reported by Charles Frey. It was in 1987 in the Annals of Surgery. This is his original paper. And here were the results that he obtained in a cohort of 50 patients. 75% had relief of pain, 11% postoperatively had progression of their diabetes, 64% increased weight, and he described post-surgical narcotic utilization as minimal, but without a number. And here you can kind of see, by extending the kind of classic Puestow to include the head of the pancreas, you then set up a target for the limb to completely drain the organ. Within the very same period of time, Berger produced these results, which are almost identical to Frey. And it's arguable who was first. Berger was probably first by a year or two, but in the strict ordering of sequence, technically Frey was ahead of him, but certainly Berger had been doing this prior and for longer than Frey had been. And Berger is a German. Of course, Frey was in the United States. But when you look at his operation, this is his original drawing, and it shows what the goal of the Berger is, and that is to preserve the duodenum with a small rim of pancreatic tissue. Here's your common bile duct, your pancreatic duct, and your major pancreatic duct. So this is going to be his target for the limb, which, as you can see, is a lot more sophisticated, a lot more complicated than the Frey procedure. And what he did in his series was triple what Frey's was and published within 2 years of each other. And what he did is on 2/3 of the patients, roughly 75 to 80 patients, he did the limb to completely enclose both the distal pancreas, biliary tree, and major pancreatic duct. And in another 25% of patients, he extended that and extended a Puestow onto them and extended the limb out even further. And just to quickly go back, you can see that he essentially produced almost the identical results. So the question really became, which one do you use, right? And there were a series of at least 4 different prospective randomized trials trying to figure out which one was better, the Berger or the Frey. And the bottom line is it depends on the center, and it depends on the principal surgeon's experience. As one could imagine, the people who did the Berger were quite gifted technically, and as a result, they tended to have better results than the Frey. And even when you looked at the Berger versus the Whipple procedure for inflammatory head of the pancreas results, the Berger always came up in single center studies better than the Whipple, both for length of time, blood loss, minor improvement in hospitalization. So, but again, these were all isolated centers with a lot of performer bias, a lot of surgeon bias. So the kind of best paper that came out last year in the Lancet, and it basically was an 18-center European study that compared the Whipple versus the Berger, principally. And what it showed was there were 250 patients across 18 centers, and at the end of the day, there was no significant difference between the total pancreatic procedure and the partial pancreaticoduodenectomy between the groups. So at the end, any one of these techniques actually can be tailored to the patient to deliver relatively similar results depending upon what you find, how much extra pancreatic disease they have, and where the disease is within the pancreas. So that's a lot in a little bit of time, but the bottom line is that the operative therapy is clearly superior to medical therapy for chronic pancreatitis. And it really requires an approach tailored to the patient. Overall, the results are what they are. They're not particularly good over the last 30 years, but in individual cases, particularly the alcoholics, of which most of these studies were the major cohort, cessation of alcohol plus surgery may deliver results that are reasonable in about 2/3 of the patients. However, with respect to the genetics, the autoimmunes, and the idiopathics, much more radical procedures are necessary to completely remove the pancreas. The anatomic location certainly is helpful in planning your operation via a drainage or drainage plus resection procedure, as is the overall health status of the patient, with the Puestow being the least morbid of the group. Again, it's really tailored, specific therapy, and the most important take-home point, I think, is you have to consider all these historic operations in the context of current technology with respect to auto-islet, because every one of these is going to substantially impact or negate even the ability to recover islet cells since after that surgery is complete. So with that, I hope I've laid the table for talking about total pancreatectomy with auto islet, and I'll be happy to answer any questions you may have. Thank you. Okay.